Welcome everybody. Thank you for joining us for this edition of Carney Conversations. I'm Diane Lipscomb and I'm here with my colleague Chris Moore and our two guests who we're very excited to welcome, Dr. Zia Gökslan and Dr. Frederica Peschner. I'm going to introduce them momentarily, but I just wanted to remind everybody just at the outset, we are going to be talking about pain in this session with our two experts. And during the presentation, you'll be able to use the Q&A to ask questions at any point during this conversation. And Chris and I will be taking a look at those questions, and we'll go ahead and ask some of those questions to our panelists as we go through this discussion. So again, thanks for joining us. So it's really an incredible thrill for me to introduce our two guests today. And I'm going to give a quick introduction to each of them, but then we're going to give them an opportunity to tell us exactly how they got into studying pain or relieving pain in the case of Zia. So Zia Gökslan has an MD, and he's the Julia Stoll Professor and Chair of the Department of Neurosurgery at the Warren Alpert Medical School here at Brown. And he's also a proud affiliate of the Carney Institute for Brain Science. So Zia earned his medical degree from the University of Istanbul in Turkey, and he serves as the neurosurgeon in chief at both the Rhode Island and Miriam hospitals. I would just say, he is one of the leading neurosurgeons in the country, and certainly you've been at Brown for a few years now, Zia, but it's just such an incredibly exciting time to welcome him here at Brown from Johns Hopkins School, where he was before. So he leads the Norman Prince Spine Institute at Lifespan and is director of the Complex Spinal Surgery Fellowship at the Alpert Medical School. And Zia his practice focuses on complex spinal reconstruction, radical surgical treatments in both primary and metastatic spinal tumors, sacral neoplasms, and spinal cord tumors. So thank you, Zia. We'll hear momentarily from you. I'm just going to go ahead and introduce Frederica Peschner, who is an assistant professor in the Department of Psychiatry and Human Behavior and in the Carney Institute for Brain Science at Brown. Rike, as she likes to be known by, is also a director of the Carney Brainstorm program, super exciting program that Rike got started here at the Institute. And that program is designed to accelerate the translation of computational brain science into clinical applications and commercialization. And you'll hear a lot about that during the next hour of discussion. Rike received a master's degree with honors in physics at the University of Würzburg and a PhD in systemic neuroscience at the LMU Munich. So LMU, Rike, stands for?
Ludwig Maximilians University.
Okay, thank you. Rike's research is focused on human perception and mental health. And very beautifully merges her deep understanding and expertise in mathematical modeling in combination with behavior and brain imaging to understand the brain, body, and brain world interactions in healthy populations and in patients suffering from psychosomatic symptoms, disordered gambling, obsessive compulsive disorder, and the focus of this presentation today, chronic pain. So welcome both. This is really exciting to have you here. And I think I'm just going to do, if you don't mind, just very super quickly, just to ground us all in terms of this conversation. We're really interested in opening up a discussion about, what is pain? Pain is a perception, but what does that actually mean? But we certainly all can relate to pain. We've all felt pain. There's only a tiny, tiny, tiny number of individuals who have this kind of unusual hereditary disorder, which is kind of this congenital insensitivity to pain. A very, very tiny proportion of individuals who have that, but of course that's also an incredibly life-altering and a debilitating condition to not have any sensation of pain for those individuals who have that condition. So we're familiar with adaptive and maladaptive pain. Again, we'll talk a lot more about this, but pain is, as I think you both know, because you're in this field and passionately interested in this, this is kind of one of the most common reasons for people going to their doctor to seek alleviation from pain. Found at least 50 million adults, 1 in 5 people are reporting pain on most days or every day, or every day. Certainly very common complaints around kind of back pain, area, of course, that Zia's very familiar with, but also in the hip, knee, and foot pain. So this is a part of everyday life for many of us, but for individuals, a lot of individuals, that kind of acute pain, kind of adaptive pain sensation kind of converts into a form of what we refer a big, broad area encompassing what called chronic pain, where that becomes very maladaptive and very highly problematic, and incredible set of disorders or origins of leading to chronic pain, for which there are very few effective treatments. And again, I'm sure we're going to touch on that too. So now to our guests, the experts, and I'll start with you, Zia. So I think, you know, the audience here who are listening to this, participants, I know are going to be very interested in hearing a little bit about your background, what drew you into being a neurosurgeon, and certainly what drew you into kind of spine surgery, and a little bit about your interest in pain, to get us going. Zia,
well,
thank you.
Yeah, first of all, thank you very much for including me in the program. I'm delighted to be with my colleagues here on this call. And so my journey to neurosurgery was not a straight one. In medical school, I was interested in every subspecialty area in medicine, and then eventually gravitated towards surgery. And then actually, I started my career to be a cardiac surgeon. And as a part of that training program, I rotated on neurosurgery. I was absolutely fascinated with brain and spinal cord and central nervous system. And here we are, many years later, I'm a neurosurgeon. In neurosurgery, I was also interested in very subspecialty areas, started out in vascular and then migrated to brain tumors. And then eventually, I spent a fair amount of time as a part of my training at the University of Texas MD Anderson Cancer Center, where I got exposed to both brain tumors and spinal column and spinal cord tumors. And that's where I became very, very interested in dealing with complex problems, particularly related to neoplastic conditions affecting the brain and the spinal cord and spinal column. When treating these patients that present to us on a daily basis, we, as you might already know, the most common symptom that we have to deal with is the pain. The pain is really one of the sort of the protective mechanisms for the body. It's a way of alerting the central nervous system that there might be something wrong. Not always, but there might be something wrong with some part of the body of the patient, and then that triggers a whole set of studies, and eventually it leads to hopefully a diagnosis. And if we have something that could be treated surgically, we typically try to do that. And as you indicated, unfortunately, the problem sometimes becomes a chronic one, and the central nervous system is sort of reset in terms of the perception of the pain, and then it becomes a very, very difficult condition to deal with. But that is sort of my brief journey into neurosurgery. Briefly, to touch upon my career, I spent time at MD Anderson, then at Johns Hopkins, and then finally, I'm delighted to be here at Brown now for the last 8 years and being associated with you guys. It's been a great journey.
Thank you so much. Fantastic. Rike, please introduce yourself and a little bit about your journey and your interest in, I guess, measuring pain, but also the mind-body aspect of pain. Thank you.
Yes, absolutely. Yeah, it's a pleasure to be here. Very excited. My journey into pain is also quite long and winded one, I would say. I did my PhD really on trying to model human perception, so saying how we're experiencing the outside world and how we could model that. And from there, I moved to the ETH and started to study mental health. So really thinking about how do certain computational mechanisms in the brain, how we learn, how we perceive the environment, how is that affected in the case of mental disorders. And one of the things I realized fairly soon as neuroscientists is that we have a tendency to focus extremely on the brain, but leave out the body. There's many conditions where we actually see the emotional aspects, for instance, of a disorder, and that involves the body very clearly. So we really also have to understand what are the signals from the body that constitute and contribute to our emotions, and how does the brain regulate bodily states. And so I kind of remembered my research in perception and started to study no longer the perception of the outside world, but the perception of the inside world, namely interoception is this whole field. And from there, I got very interested in the interaction between symptoms that can manifest in the body, but may be maintained or triggered by the brain, and also symptoms that may manifest in the brain, but actually may be triggered by systems in the body. And that got me very interested in pain, where you have this bilateral pathway that is contributing partially also to the maintenance of pain. And so in order to study that in humans, I realized that we really need to not only look at pain in a particular moment, but its dynamics over longer periods of time. And so for the past 2 years, my lab has been developing a smartphone app that can be used by patients in order to track pain over longer periods of time. And we're exactly studying the brain-body interactions involved in pain since then.
Thanks, Rike. Maybe I'll go ahead with, just as you're ending there, and pose this question to you. It's a difficult one, but I know that you're really interested in measuring pain, and perhaps a place to start here is to ask you, like, how do you define pain? And then as you talk a little bit about, you're thinking around how to measure it and how individuals measure pain. And I really loved, maybe there's a way to also kind of link, I loved your introduction of interoception and the difference between, that and kind of external versus internally generated signals. So there's that's a big overarching thing, but perhaps starting, what is pain? How do you define pain? And then how are you thinking about measuring it? Why are you particularly focused on measuring it the way that you're going to tell us that you're trying to measure it?
Yes, absolutely. An easier way to define pain is by sometimes saying what it's not. And I think one way to describe it very well is to say it is not necessarily nociception. So there are sensors in the body that detect, for instance, higher temperatures, or that detect potential or actual tissue damage, and they project to the brain. They are called nociceptors, but that doesn't necessarily mean that you're experiencing pain. So pain is the experience. It's an interpretation by your brain whether something is actually a physiological threat to your body. And that's a very important point, because it can mean that there's no damage and you're experiencing pain. It can mean that there's a lot of damage and you're not experiencing pain. And that in and of itself already means that it's highly context dependent, and it's a very subjective measure. And part of what has been tried to do in the past is to say, can we come up with objective measures of pain? And specifically kind of large providers like Apple, they've tried to use sensors to detect pain, but they're now shying away from it because there is no good objective physiological readout that tells you whether someone is in pain right now. A more promising set of biomarkers that people have started to look at is actually brain imaging, to say, is there a particular state of the brain where you are currently in pain? And funny enough, acute and chronic pain have very different signatures in the brain that has been observed in the past. What we are trying to do here is to say that we acknowledge the fact that it is subjective. And what really matters about pain is how distressing it is to you as an individual. And so we're not just measuring pain intensity in a self-report, but we're also asking individuals about unpleasantness and about the interference with their daily lives, because we think that that is part of your recovery, is really dependent on how much you can still do in a particular context and in a particular experience of pain. That's a short answer. There's a longer version of it for sure.
No, that's fantastic. And Zia, perhaps a reaction to Rike's beautiful description and very complex description of the perception, of pain, and then, how you, as a neurosurgeon, you're obviously part of that is diagnostic. It's like you need this, response, this verbal response from individuals, like how much pain are you in, where does it, like, what would help you, how do you assess pain, and then what would help you, in your daily life as a neurosurgeon, thinking about, like, are there better ways to try and measure pain, and are you, how are you reacting to Rike's description?
Well, first of all, I have to acknowledge that Rike's description was absolutely beautiful. I was mesmerized when she was sort of covering all aspects of the perception. As she indicated, this is a very difficult symptom for us to measure, and it is subjective. So we really rely on what the patients are reporting to us in terms of the degree of the pain that they experience. And it is altered based on a lot of other emotional input of the state of the patient. That perception is modified, altered, modulated, and even in the same patients, under one set of circumstances, the same external stimulus can generate one level of pain, which is a certain level of perception associated with that stimulus, and under other circumstances, the same stimulus may produce a different perception and different level of pain. So that makes it even more difficult. The patient's emotional state is a very big factor in the way that they perceive their pain. But nevertheless, in our practice, we try to measure it, and we rely on what the patient is reporting. And the simple way to do that is to come up with a scale from 1 to 10 and ask the patients how severe their pain is in a given location, and they give a numerical sort of feedback related to that, and then we do some sort of intervention, either medical or surgical or other. And at the end of that period, then we ask the patient how their pain perception is and what that numerical value is. And then we try to compare that to the pre-treatment state. And we try to get a sense whether or not what we did really has had any significant impact in reducing the pain. So that sounds very simple, and it is highly subjective. And there is a whole, as you know, placebo component to that. And so there are drug trials where if the patient believes that they are getting a therapeutic drug that would alleviate their pain, and their pain improves significantly. And on a visual analog pain scale, that change can be as many as 3 points. And so in measuring the pain in terms of our impact of our treatment, we actually ignore that 2 or 3 point change in the pain, because all of that could be attributed to just having the placebo effect. And so we rely on the fact that the change is going to be more significant than that, maybe 4 points, 5 points, 6 points. And then perhaps that's clearly related to your intervention. And if you look at the patient's brain imaging and the PET scans, and you can see activity associated with placebo perception. You give it a placebo drug, and the brain's reaction, the parts of the brain that perceives the pain, is exactly the same as if they are getting a therapeutic drug. And so that implies that the brain can be tricked, and you can really alter the pain perception significantly as a result of that. But it's a very difficult thing to measure. Of course, we look at other correlates. Usually when you have an unpleasant experience and you're hurting, there's a sympathetic response and a lot of things change. Your heart rate goes up, but you may be sweating. The respiratory rate goes up, and sweat. You could measure some of these things more objectively. And then finally, one of our researchers here in our department a number of years ago really has been doing very interesting studies looking at the EEG waveform patterns before an intervention and after the intervention in patients who have been experiencing both migraine headaches and spine-related pain. And he was able to demonstrate that there are certain EEG signatures that you can detect as a sort of a biomarker for the pain. And he has a patented sort of a description around that. But maybe I'll just stop there. It goes to show me that it's a very difficult thing to measure. It's highly subjective, and the emotional state of the patient will determine how severe the pain is.
So let me just, first of all, also thank you both for being here. It's kind of amazing is a better word, more just to have you both at Brown. I mean, the very, very different, but maybe very similar, like really advanced methods you're using for beginning to address this from a variety of different angles. It's whatever, it's a stunning moment to have you both in the community. So it's really neat. So I am really excited also though to have you both on the same call, because it feels like there could be a really great synergy in this. That's obvious, I guess. But Zia, when you're considering patients, a million years ago, I used to work with chronic pain patients, spinal phantom patients, right? And we would give the visual analog scale, and they'd get a questionnaire about daily life and interference and stuff. And that was I tried to be cutting edge at the time. That was about as deep as I could go. Like I couldn't find anything better as a way of assessing it. Not that that was bad. It actually seemed to capture their discomfort well. Do you have a certain number of months that they have to be in pain? Do you have, when you see most of the patients you see, maybe that would be the most maybe directed way to ask my question. Is there a phenotype to the patients that you see? Are they're mostly dealing with tumors also? And the treatment that you would be giving through surgery is in that, in other words, do they always have a sequelae that's another physical symptom like a tumor that goes with then the treatment for pain on top of it in the cases that you're usually dealing with?
Yeah, so that's a good question. I would say that at least in my practice, more often than not, we are dealing with pain that is a nociceptor, which is, the pain receptors are signaling to the body that there is something seriously wrong with one of the organs or one region of the body. And so in the patient that I treat, often we are dealing with acute or subacute pain. The patient has been experiencing pain for a short period of time, and usually it's quite severe. If you look at spinal column, for example, which tends to be a significant source of pain, we simplistically divide it into different categories where the pains might be coming from. So one way to think about this, you have nerves in the spinal canal, and the nerves can be compressed, and a disc herniation or a bone spur can irritate the nerve root, can cause local inflammation and pressure on the nerve, which perceives, which detects the pain signals or external stimuli, and that gets transmitted to the spinal cord and goes to the brain. And then here we are, you're experiencing pain as a result of pressure of a nerve root in this particular instance, or you have a tumor that creates a local inflammatory response, produces a number of chemicals that could be irritant to the receptors that signal the pain back to the central nervous system. In some cases, actually the bone is broken, just like you break your leg, spinal column. Believe it or not, the vertebral body can collapse or break, and that could produce what we call mechanical pain, where it's exacerbated by movement. And so I deal with the patients typically with acute pain, and the pain is quite severe, and it's most likely related to an organic cause. We can typically identify that, and it could be related to compression of the nerves or local inflammation, or mechanical issues related to fracture of the bones or collapse of the vertebral body.
Thanks. That's great. That's great context. Is it fair to say, Rike, that we were talking about acute versus chronic, and that might not be the right axis to think of this on, but when you're using the Soma app or the goals of the Soma app, what kind of patients or people do you envision, I don't know, best collecting data from / best benefiting from its use?
Yeah, that's a good question. Actually, we look at both. So we're very interested in the transition from acute to chronic. There are certain theories that are looking into whether the brain keeps on maintaining pain because it has learned pain. And so that can, for instance, be the case if there is a severe trauma after certain surgeries or injuries, there's a high percentage of individuals transitioning from acute to chronic pain. So for instance, for rib fractures, depending on the severity of the rib fracture, the exact location, it can be around 40%, which is fairly high. And the question really is, can we predict early on who is at risk of developing chronic pain during that phase? And right now, if you have an acute injury and you continue to experience pain, there's little follow-up. So you're changing your physician. So you're continuously reporting pain, but up to the point when you're actually receiving more dedicated treating to what has become chronic pain after 3 or 6 months, takes a very long period of time until you receive the care that you need. And at the same time, we're also very interested in chronic pain. There, the question is, for instance, what certain activities are actually triggering flare-ups, that's peaks in pain or sparks in pain over several periods of time. So basically, we try to target both groups, which is a bit unique in what we're doing in comparison to what others are currently doing when they measure pain. And we are also looking particularly at time windows around an intervention. So we are planning a study where we actually look at patients pre and post spinal cord surgery, spinal cord stimulation, and also radiofrequency ablation to see what are the dynamics prior to the treatments and then post treatments, because often you tend to have a flare up in pain, for instance, for radiofrequency ablation, and then it tends to go down over the course of several weeks or months. But then after a while, it can also happen that it comes back on. And so that's the exact dynamics that are not very well understood, but could tell us very early on if we could intervene earlier.
That's really interesting. So it sounds like there could be a direct connection there, obviously. We're all on the phone call and we've all talked, so that's not a surprise, but that's really neat. One question I wanted to ask you about, Zia, is, and I realize that in talking with both of you, the technical details, we want to make sure we just, you're dealing with really rich topics here, but there has been a fair amount of innovation in spinal surgeries in the last 20 years. Is that a fair characterization? Maybe you can give us a sense of where that's at in terms of a point of progress and understanding how the nervous system can be treated.
Yeah, so there has been a significant progress, yes, as you indicated in spinal surgery. I think that the general trend is moving from more open traditional type of surgical approaches to more minimally invasive, less tissue destructive procedures. As a matter of fact, the procedures that you so minimize the tissue damage that you really are able to almost eliminate it completely. Just to give you an example, we have an expert in our department who specializes in endoscopic spinal surgery. So he typically treats herniated discs that compress the nerve roots and can produce excruciating pain. When we do these operations openly or more traditionally, typically we have to make a bigger incision, we have to move the muscles aside, and we have to access to the disc by removing a portion of the spinal column and identify the nerve root, and then remove the disc and relieve the pressure on the nerve root. That's sort of the traditional way of doing it. But the endoscopic way of doing it is, as opposed to the patient being asleep, they are first of all awake. The operation is done through a pencil-sized incision. An endoscope is guided. You don't really have to remove any bone. You're really targeting this directly to the disc. You can see the nerve root at the same time, and you remove the disc material and relieve the pressure on the nerve. As you can imagine, all the pain that the patient would have experienced as a result of the tissue destruction in traditional surgery is essentially eliminated because you don't have to do any of that. And then also all the negative effects of removing bone and destabilizing the spine and creating mechanical issues and so forth, that can also be eliminated. But that's just one example of how the surgery really moved from open traditional to very minimally invasive interventions as such to minimize the tissue damage. As far as other pain interventions are concerned, for example, we use a spinal cord stimulator as a device, right? The spinal cord stimulator is something to be typically used in patients with chronic pain. We typically use in patients what we call with neuropathic pain. So we don't really have a clear reason why the patient is still experiencing the pain, but clearly the nerves, nerves are signaling that as if there is something wrong there. And the strategy here is really to place a electrode against the spinal cord where the pain signals enter to the dorsal columns of the spinal cord, and we can literally jam the electrical signal there. We create a competing electrical signal which prevents the pain signals to get into the spinal cord effectively and gets transmitted to the brain. And in well-selected patients, this is a highly successful surgical intervention, and it is one way how you can sort of treat the central nervous system and alleviate the patient's pain. That's very simplistic and perhaps a superficial explanation of how the spinal cord stimulator works, but for neurosurgeons, it's a pretty straightforward thing to understand.
And could I just follow up just a little bit on that? The direct nerve stimulation, as you said, to kind of jam up the system. Why would that be more? Is that an ongoing thing, or is it just and then why is that more effective than, there are many drugs that we know of that would inhibit, conduction of signals through the nerves. So can you give a little bit more insight into that?
So the jamming up the signal was a very simple explanation.
No, it's great. It's perfect.
I mean, idea here is there are electrical signals that are being transmitted by the nerves into the spinal cord, which is going to produce the pain sensation when they get up to the brain, right? So if I can reduce the amount of electrical signals that are coming from the altered nerve, and I can minimize that entry into the spinal cord, I can reduce that sensation effectively. You can think about competing signals, creating competing electrical signals that are not necessarily painful. And by doing so, we are preventing the entry of the signals that would produce pain otherwise. And so that's sort of the simplistic way of the other drugs. And there are a whole series of drugs that we use in treating pain. If the pain is related to inflammation, anti-inflammatory drugs work beautifully, right? So you can use steroids or non-steroidal anti-inflammatories very effectively. If the pain is related to neuropathic pain, as in the case we use a spinal cord stimulator for, we can use drugs like gabapentin or pregabalin, and those medications tend to raise the electrical stimulation threshold for the nerve. So it is more difficult to stimulate the nerves with the electrical stimuli, the stimuli that's coming from outside. Or we have drugs that not only affect the peripheral nervous system, but also centrally can reduce the signaling or suppress the signaling in the central nervous system or in the relay stations in the brain, and that could reduce the pain perception. Tylenol is a good example of that, or a lot of the endorphins, which is body's own morphine system that does that. So there are various ways we can use those medications, but you have to remember that many of these medications have really significant side effects, and they cannot be used for a long time. And sometimes the side effects are worse than the pain in some cases. Electrical stimulation, although it's an invasive intervention, it is targeting exactly the area where the pain is entering into the spinal. Pain signals are entering into the spinal cord, and furthermore, it is constant. So you set it to a certain stimulation level, and it constantly stimulates the spinal cord. And so that's one way of avoiding the side effects of the medications and still getting the same result in terms of pain control.
Great. And that constant stimulation is almost filtering out a certain frequency of signal, but letting through lower frequency signals?
The short answer to that, it does. And sometimes the stimulation is strong enough that it actually is uncomfortable for the patient. And this is generally adjusted. So you sort of find the optimal stimulation parameter for it is individually different. So it's different from one patient to another. And so you have to, first of all, we do a test trial before we implant the device to see whether or not the patient is going to benefit from that. And after the device is implanted, externally, you can adjust the stimulation levels that could be best tolerated by the patient without causing any significant side effect.
Great, thank you. Thanks, fantastic. And so it dovetails really beautifully, I think, Rike, with your, your very sophisticated thinking around how to measure pain across individuals. And I think Zia's description of the multiple ways that one can treat pain depending on its origin and depending on the kind of pain. And I think it would be really great if you could perhaps expand a little bit on the Soma app that you talked about, but once you have certain much more granular and deeper meaningful information about measuring pain, its origins, presumably that ultimately, of course, is going to be hugely informative in terms of treatment. So I wonder if you could kind of jump there for us and give us a little bit more information about how you're thinking of extending measuring to treatment.
Yes, absolutely. So one of the studies that we're actually rolling out right now is one where we're going to look at radiofrequency ablation, and we're going to look at it. So basically, before you do radiofrequency ablation, you first add a nerve block. So it's really targeting the same system. And you try to see, is there pain reduction after the first nerve block? Is there pain reduction after the second nerve block, which is usually about a week later? And then actually is when you decide to have a radiofrequency ablation. And what we can now see is the entire dynamics around the nerve block for the first one, the second one, after the ablation, and then how the pain is changing over longer periods of time. So that's one way where it is very related to how do peripheral interventions actually dynamically change pain levels. One of the things that we are currently working on is to say, well, can we use these time windows where there is a change in pain, specifically in patients that have been experiencing pain for a very long time, as a window of opportunity, so to say. So there is already a peripheral change. Can we use that to relearn some of the central processes that might be maintaining pain? And so what we're trying now is to develop an intervention that is given particularly prior to a peripheral intervention. So for instance, you do breathing exercises, there's a meditation right before you have a radiofrequency ablation, and then we have a program that follows up over 6 weeks. So the idea is to support existing peripheral interventions with more cognitive processes to see, can we improve treatment outcomes for patients by combining a body-based intervention with a brain-based intervention at the same time. And so this is something that we are actively working on. We hope to release as kind of a second part of SOMA. So right now we're doing the tracking and the evaluation of that. And then the second part, we want to intervene as well.
That's great. So really very much a real-time feedback.
Yeah.
and adjusting that intervention is beautiful. Yeah, thank you. Chris, go ahead.
Yeah, it's just, again, it's so cool to be at the intersection of where you two are with this, of following up with what you're saying, Rike. As I think I'm the only one on the screen born in the United States here today on this particular call. And pain is really deeply impacted by cultural influences, potentially at least. Like, it doesn't have to be. Certain kinds of pain probably aren't, but there's lots of recorded differences culturally. Soma can get at that. Soma can't get at that. Is this something the app can do?
We have a collaborator right now who would like to translate the app into Hindi, and I'm German, so the next version of it will be in German. And the idea really is to say, are there cultural differences across different countries and nations? And particularly, we combine this. So the person we're collaborating with is actually an anthropologist and really interested in the conceptualization of disease in different countries. And it would be very interesting to see how the conceptualization of pain is different, and thus the experience of it is different as well across countries. And I can give you a couple of very interesting examples of why I think, wording matters. For instance, in Germany, when you have a car accident, I think there's a fairly high % of accidents that will result in a whiplash injury. So it's actually neck pain that is coming from the car accident. But then there's other countries, and I think it's Estonia, correct me if I'm wrong, where whiplashes injuries don't exist. It's just not a thing. So after an injury, like after car accidents, nobody's reporting neck pain. And so someone did a study in Germany with fake car accidents. So there was no impact, but there was a crash and there was like glass was spreading around while the participants were sitting in a car. They literally did this type of study to see if they were reporting any experiences of a whiplash or pain or distress and so forth. And they started to. I mean, it's one small study, but it points to this idea of expectations play a huge role of whether we're experiencing pain and whether we may be experiencing certain types of pain syndromes. Another interesting aspect that I saw a commentary here, a commenter in the Q&A asking about the opioid epidemic in the United States. Well, in India, there is also a high number of opioid abuse, but it does not come from opioid medications. So even though you have similar numbers, it seems to be that these come from drug abuse. So why is it? Like, what is the overall percentage of people who suffer from an opioid use disorder? And what are their different paths into that? In the US, pain is a big reason why people started to take opioids in the first place and became addicted later on. So to look at these cultural differences, I think is going to matter a lot in order to understand why we're experiencing this epidemic here in the country.
Yeah, and it's so interesting given what Zia was saying about the, moving 3 points on the visual analog scale. That can be transformative. In other words, placebo, as we all know, it's just a wonderfully powerful way of addressing aspects of pain because of its deep cognitive, cultural component, right? That really complex executive function kind of relationship, maybe. So it's really neat to think of being able to begin to tease that out, because obviously if one could leverage that as you're starting to, maybe with meditation or with breathing exercises and other interventions that go to that, it seems really powerful.
Yeah, so
And sorry.
please, right.
Just one aspect about the placebo that I think, because we're talking so much about perception, and I think the classical belief that is still so common is that the placebo effect is a sheer change in perception. So I'm expecting to feel better and therefore I'm feeling better. But I really love the latest research on the placebo effect, looking at what is it actually that is causing the placebo? And it seems to be that it's an endogenous opioid release. So in other words, there is this descending pain pathway that can actually block ascending pain information that is coming from the body. And if you think about that, that means it's an endogenous drug. It's really mimicking the effects of exogenous opioids like morphine. But even more importantly, if you now think what the brain does, it's an actual action that we're taking. As much as we can pick up a cold when we're cold, we can also release certain hormones or neurotransmitters in this particular case that are affecting our internal states. And so it's not just a percept, there's much more than that. It's a regulatory process that is taking place in the brain that's effectively changing the way we're processing sensory information. And so now that we understand the biological underpinnings of the placebo, I think it leaves a realm of, oh, that's a just so explanation of perception to actually something that can be physically measured. And there's a very neat experiment where you can block the receptors giving someone naloxone. So that's a medication you would also give someone on a heroin overdose, for instance. And turns out if you give patients on a placebo effect, naloxone, it blocks the placebo effect. So there you see where there's really clear biological underpinnings for things that we're observing here. Sorry.
Yeah, so some of the differences that we see also related to not so much the difference in perception of pain by different cultures, but expression of pain. And so what we rely on subjective reporting of the patient of how they are feeling. And I can speak as a surgeon that I've seen patients and I know the condition is extremely painful. Somebody with acute peritonitis, for example, we know that it's a very painful condition. And by all the biological markers, i.e. heart rate, respiratory rate, and sweating, etc., the other things that we see as a correlate to pain, and the patient is expressing all of that. And yet, when you ask the patient whether or not they're in pain, their culture doesn't allow them to express pain in an open manner. And the patient can say, no, I am not in pain. But by looking at the patient, you know that the patient is in pain. By looking at the heart rate, you know that the patient is in pain, but they do not openly express that they are in pain. So there is that element of that as well, because we rely on the patient's reporting subjectively in assessing the severity of their pain. And so I think that also plays into how individual cultures can affect how the pain is sort of measured by the observers at the bedside when they are experiencing a medical issue.
Yeah, it's really incredibly important, and it really speaks also to the very well documented under treatment of pain, certain categories of individuals when they're not again, like in their culture, they're not going to verbally complain about being in pain, but there's a lot of individuals who really go undertreated and then perhaps overtreatment in the other direction, which was part of the question that came in with regard to opioids, and really linking, like, so you must need a much more less subjective measure of being able to assess pain in that case. And would that help just in terms of being able to prescribe in a much more perhaps rational way, painkillers for individuals who are experiencing it? So I think I answered my own question, but I think your discussion was really relevant to that question that came in. I did want to perhaps, I'm looking at the questions now and looking at the time, but there was a very interesting question that came in. I'll take one, maybe Chris will take the other, but they came in about anesthesia. And Zia, going back to your comments about kind of the advances in neurosurgery and being able to operate in very complex conditions without the need for general anesthesia is incredible. But is there something more interesting here as well in terms of recovery of patients who have to undergo kind of general anesthesia versus local nerve block? Do you see, obviously recovery is faster, but is there any longer term implications for recovery from surgery and or longer, shorter term consequences post-surgery in terms of pain? Or is it simply just don't go under general anesthesia unless you really need to?
Yeah, so first of all, I think general anesthesia, particularly prolonged general anesthesia, has certain side effects, definitely does have a certain impact in the brain. And we know, for example, the people who have predisposition to dementia, when we subject them to prolonged surgical procedures, not uncommonly, those patients experience postoperative delirium. As a matter of fact, we see that as a concerning sign that these people are going to develop dementia, sometime after the surgical procedure. It doesn't necessarily mean that the anesthesia itself is causing that, but it is putting the patient under general anesthesia can create a set of circumstances where the delirium is a sort of a surrogate for dementia down the line. And so there's no question that general anesthesia does have significant impact in brain function. We know that during the administration of the anesthesia, and of course, it takes sometimes a long time for the patients to wake up from the surgical procedure, sometimes days, to get back to normal. And being able to do the procedures using local anesthesia, blocks, or spinal anesthesia, it's always preferable so that you can spare the central nervous system from the effects of general anesthetics. So there's also some concern in younger patients, again, related to general anesthesia, that it may impact the brain maturation in those individuals. And so we use it, liberally in our surgical practice because we need it. And the other component of it I need to sort of interject here, that as you know, pain is a very distressing symptom because you remember it. And so if you're able to suppress the patient's memory, and we do have drugs that do that very effectively, during the procedure, the patient may be in significant amount of pain and they are highly distressed. But if you give them a drug right after the procedure and basically wipe out their memory related to the surgical intervention, after the surgical procedure, the patients really have no long-lasting effects of that experience. So it goes to show you how the memory of pain plays such a significant role, setting the circumstances for chronic pain and other conditions down the line.
Thank you.
Maybe I can directly add to that. There is actually beautiful animal research where they looked at the hippocampus and lesions in the hippocampus in mice that had experienced neuropathic pain. And you can really alleviate the pain by lesioning the hippocampus. Obviously, it's for those, like, this is the memory center. Obviously, in humans, you don't want to do this. This is the place where you store and link to memories. But at the same time, it explains exactly what you're saying, is that there is a memory of the pain experience that can contribute to the maintenance of long-term pain. And similarly, actually, they found that the same thing is true for the amygdala. And there's many purposes that the amygdala had, but it clearly is also associated around with the fear and the threat that has been attributed to the sensory signal that is coming into the system. And so that might be a much more promising target also for humans.
Yeah, it really underscores that this is a problem that goes from the highest cognitive level to receptor channels, as Diane also studies in her lab, right? It goes all the way down to single, maybe even to single splice variants, and includes all of the body, all of health, in the richest way. It's like the purest form of a cognitive or consciousness problem that's undermines somebody's status or ability to focus on what they want to focus on, in a way, right? That's something. One of the questions that came in is about sort of different aspects of pain. So what is the difference on a physiological level between burning or tingling pain versus more familiar kinds of pain, like sharp and dull? Would either of you like to weigh in on this?
Well, so the receptors that are peripherally situated, the receptors that, if this is nociceptive pain, assuming that that's coming from the periphery, and two-point discrimination is a very precise differentiation of the sensation in the periphery, and this is carried, detected and carried through a different set of nerve fibers versus a pressure-related, for example, dull pain. And the receptors for that are separate, and then there's a different pathway that carries that through the spinal cord. And so basically specific wiring for different types of pain within the central nervous system can very well be the differentiating factor here between the two types of pain.
Thank you.
We've got about 5 minutes left, which is always extraordinary to us because it feels like 10 minutes went by. But there's probably a couple, we can probably hit maybe 2 more questions. And I have a follow-up, and maybe Chris can do the last question. But one area we just haven't even touched on, and there's so many different possible places we could go with this, but you know, we haven't talked about pain during development. And I mean, some years ago, I was talking to someone who works in the NICU, and they were telling me how incredibly different, you know, infants respond to stimuli, and like the real challenge there, and to understand whether, you know, a baby is in pain or not, like their sensations are very different. And then as I was thinking about that, And also that your comment about memory, the memory of pain, I think we all know very clearly, those of us with kids, like that we remember things that happened to them and they have absolutely no memory of these very dramatic events that kind of like, I have it burnt in my head, right? It's like every moment that they were in pain. So that, I wonder, is that, I mean, it's so interesting, isn't it? Like we know a lot, we know so little. And then like the involvement of that memory of the event, the replaying of that, every time you're remembered of something, like we're replaying it constantly. I mean, is there something that or perhaps you've studied, or you can perhaps contribute here in terms of like this, kids forget, like they don't have this consolidation of a lot of events that happen very early on. That's a protective mechanism. And then later on, of course, these incidents are just burned in our heads. And so it strikes me there's probably a link there and a correlation in terms of, their ability to be able to cope with a lot of stuff going on. Go ahead, Nadir.
By no means I'm an expert on this, so I take it with a grain of salt. So I don't understand the basic physiological and neurological mechanism behind this. Yes, like you said, I think that a lot of the kids who have had some bad things happening to them at a very young age, they absolutely have no recollection of that. Whether or not that's really completely suppressed, or you were able to extract that, I don't know the answer to that. We do know that the people with post-traumatic stress syndrome, they have a whole set of issues that they have to deal with after experiencing a very traumatic event. And in some cases, they don't even remember what it was. And you have to really go through a extended psychiatric evaluation to be able to bring that to the surface, to the memory again, to be able to really deal with it. And so based on clinical observations, that definitely happens. Why it happens and how we are able to do that, I don't really have a good answer for that. Maybe Rike can give us some perspective from the basic science side.
I don't have a good answer either, I would say. But what I can say, what I find fascinating about pain later on is that we experience one-shot learning, which is actually quite unusual. Humans, usually takes us a little bit to learn something. Pain really allows us to do one-shot learning. In one single trial, we've learned the whole associations with a particular context, in part because it is so salient and it's so important that we don't repeat the same mistake.
For sure.
And so, but that also means you have a very good estimate of the context that you're in and of itself. You understand the relationships, you understand what has been causing what. And as a child, I think a lot of what we do is trying to learn causal relationships, and a lot of accidents that happen to children are actually quite surprising to them, and they cannot trace them back to the particular thing that they might have done because they're still learning all of the contingencies in the environment. So that may be one reason why it's not as ingrained as in when you already have a very established model of the environment. But that's my personal theory around what might be going on.
Great. Or essential for that early exploration. Yes. Otherwise you wouldn't explore. This is perfect, yeah. So
sorry.
No, go ahead.
Just one thing, the part that actually is a predictor of chronic pain in the future is childhood adversity. So that's something that has been studied and assessed. But here we're talking about continued abuse, which is a predictor of any chronic condition later on in life, actually. So
yeah, thank you for adding that. I think that's an incredibly important point and exactly right. Yeah. We're at time. Chris, do you want? I'll give you like a couple of minutes.
We have 70 or 80 more questions. I was hoping to get to the immune system and sickness and wellness and the feeling of sickness behavior, but that's all right. I'll ask each of you later, and hopefully, you can publish a paper on it and tell the rest of the world. We super appreciate it. Yeah, this is really, really great.
Yeah, so thank you so much. This was tremendous. Thanks to the participants for joining us. You posted some really great questions. Thanks for participating. That's the whole point of these conversations, which will be available later. So bye to everyone. Look forward to the next Carney conversations. Take care. Thanks, Theo.
Thank you
Thanks.
so much.
Okay.